Do you know why most women can't get pregnant for several months after delivery? Why do some patients with hypothyroidism develop breast changes and menstrual problems? Why do antipsychotic drugs sometimes cause breast milk production in men and women? And did you know which is the only pituitary hormone that is mainly inhibited rather than stimulated by the hypothalamus? The answer to all these fascinating questions lies in a single powerful hormone, prolactin. Let's dive into a detailed discussion of these questions and build a clear, crisp understanding of prolactin hormone. Prolactin is synthesized and secreted by the lactotroph cells of the anterior pituitary. Regulation of prolactin. The hypothalamic dopamine delivered via the pituitary stalk binds to the D2 receptor on the lactotroph and result in decrease the cyclic AMP production in the cells and which decrease prolactin release. And now the stimulatory influence. The thyrotrophin releasing hormone from the hypothalamus not only stimulate the production of TSH but also increase the production of prolactin. The estrogen, especially during pregnancy and combined oral contraceptive pills. Estrogen also upregulate thyrotrophin releasing hormone gene expression and ultimately increase the thyrotrophin levels, increase the TRH, results in increase the prolactin levels. Also estrogen, this is the dopamine synthesis pathway, and here the estrogen downregulate the tyrosine hydroxylase and aromatic L-amino acid decarboxylase in the tuberoinfundibular dopaminergic neurons, result in decrease the synthesis of dopamine and which decrease the tonic inhibition on lactotroph, resulting increase the prolactin level. Now the oxytocin. Oxytocin is released from the posterior pituitary in response to suckling, which causes the milk ejection by the contracting myoepithelial cells in the breast. At the same time, the suckling stimulate the hypothalamic pathway, which decrease the release of dopamine and ultimately increase the prolactin secretion. So oxytocin indirectly support prolactin secretion by reinforcing the suckling reflux loop. Now serotonin. Serotonin also stimulate the prolactin releasing factors, for example TRH, and which ultimately act on the anterior pituitary and result in increase the production of prolactin. And serotonin also inhibit the tuberoinfundibular dopamine neuron, result in decrease the dopamine tonic inhibition, result in more release of prolactin. So direct evidences come from the pharmacology drugs that increase the serotonin level, like SSRIs like fluoxetine, LSD, fenfluramine, and some anti-migraine drugs, for example triptans, increase the prolactin level. These can sometimes lead to galactorrhea, amenorrhea, infertility, and loss of libido. REM sleep. Stress. A physical, for example surgery, exercise, or psychological stressor, for example anxiety, fear, is perceived by the brain, which stimulate the hypothalamus. Hypothalamus stimulate the release of corticotropin releasing hormone under the stress. Beside its job of stimulating ACTH and cortisol, a corticotropin releasing hormone directly act on the pituitary and bind to the receptor on the lactotroph cells and stimulate them to produce and secrete prolactin. And hypothalamus under the stress also stimulate the TRH release, which increase the further prolactin level. Now the exercise. Exercise is also a kind of stress. Hypoglycemia, nipple stimulation also stimulate the production of prolactin. What is the physiological function of prolactin? The first one is the breast development. It promotes labulo-alveolar growth. Lactation. The prolactin helps in copious milk secretion during postpartum when the progesterone fall and also maintain the milk production. On reproductive axis, the increased prolactin level decrease the pulsatile GnRH release, which decrease the release of LH and FSH and lead to hypogonadotropic hypogonadism, which is the temporarily contraceptive effect during exclusive breastfeeding. That's why the woman can't get pregnant for several months after delivery because of decreased level of GnRH, LH and FSH due to the increased release of prolactin. Hyperprolactinemia. The cause of hyperprolactinemia. The physiological causes: pregnancy, lactation, stress, exercise, REM sleep. Pathologically, the primary hypothyroidism because of increased level of thyrotrophin releasing hormone. The pituitary adenoma. The pituitary adenoma either increase the prolactin levels or decrease the dopamine level. Hypothalamic or pituitary stalk lesion. For example, if there is any trauma, sarcoidosis, or metastasis. Chronic renal failure. Because of decreased clearance, there is build-up level of prolactin in the body due to decreased clearance. Cirrhosis. Like kidney, liver also helps to metabolize prolactin. Impaired hepatic metabolism because of cirrhosis lead to the prolactin accumulation. Also in the cirrhosis, there is hypoestrogenic state, which also increase the prolactin levels. This is also explained why cirrhotic patients develop gynecomastia, testicular atrophy, and infertility. Any chest wall injury, for example herpes zoster and burns, which is also a kind of stress response to body. Pharmacological, as dopamine inhibit the prolactin release, and dopamine antagonist increase the prolactin levels. For example, antipsychotics like risperidone, haloperidol, metoclopramide. Serotonergic drugs also increase the prolactin level. For example, SSRIs, TCA, MAO inhibitors. Estrogen, opiate, cocaine, cimetidine increase the prolactin level. Clinical manifestation, as increased prolactin level inhibit the GnRH release, which inhibit the release of LH and FSH levels, lead to decreased estrogen, progesterone and testosterone levels. So increased estrogen levels increase the prolactin levels in the body, but increased prolactin levels indirectly lower the estrogen levels by suppressing the hypothalamic pituitary gonadal axis. So lowering levels of LH, FSH lead to anovulation, oligo or amenorrhea, infertility and decreased libido. There may be galactorrhea because of increased prolactin levels, dyspareunia, as estrogen maintains vaginal epithelium thickness, elasticity and lubrication. Decreased estrogen levels lead to vaginal atrophy and decreased lubrication. That's why there is dyspareunia. Acne and hirsutism because of relative increased androgen levels. Look above, we said that there is decreased testosterone levels. And here we says there is increased androgen excess. Why? Because estrogen increases the hepatic sex hormone binding globulin levels in the blood, as we discussed in the previous lecture. The hyperthyroidism also increases the sex hormone binding globulin gene expression. So increased production of sex hormone binding globulin, the more binding of testosterone to these sex globulins result in decreased free androgen levels. but total testosterone, bind plus free, is high. And suppose normally we have 40 testosterone molecules, and out of which 35 are attached to sex hormone binding globulins and only 5 are free. And now because of decreased LH and FSH levels, there is decreased production of testosterone and estrogen. And suppose now the production of testosterone is bring to 20 from 40 molecules, and simultaneously because of decreased estrogen levels, there is decreased production of sex hormone binding globulins. Now the less hormone is bound to the sex hormone binding globulins because of decreased estrogen levels. Suppose out of 20 only 5 are bound to sex hormone binding globulins and 15 are free. So the total estrogen level, that is free plus bound, is low, but the free level is increased in case of hyperprolactinemia. So increased free level of testosterone, which is the active form, and also progesterone inhibits the 5-alpha reductase. So decrease the conversion of testosterone to dihydrotestosterone. So decrease the progesterone level, lead to the increased conversion of testosterone to DHT because of reduced inhibitory effect of progesterone on the 5-alpha reductase. So DHT also increase. So result in increase the relative free level of androgen, which cause the acne and hirsutism. I hope this is clear. And in case of male, there is decreased libido, infertility, erectile dysfunction, decreased muscle mass because of decreased level of testosterone. There may be galactorrhea because of increased prolactin level, maybe gynecomastia, as increased prolactin promote the breast growth. There is also osteoporosis, and other clinical manifestation is due to the mass effect of macroadenoma. Because of the mass effect of the macroadenoma lead to headache, bitemporal hemianopia, and cranial nerve palsy. And now the treatment of hyperprolactinemia. The goal of the treatment is to normalize prolactin level, restore the gonadal function, shrinkage of tumor, and preserve vision and bone. Dopamine agonists are the first line of treatment. Cabergoline 0.25 milligrams once or twice weekly have higher efficacy and better tolerance than bromocriptine. Bromocriptine is another dopamine agonist, 1.25 milligrams at bedtime or 2.5 milligrams in 2 dividing dose. Transsphenoidal surgery if there is presence of pituitary adenoma. Radiation for aggressive or residual tumor unresponsive to drugs. Special scenario if the hyperprolactinemia is due to the antipsychotic induced. If drug can't be stopped, use lowest effective dose and switch to aripiprazole, that is partial D2 agonist, or add a low dose cabergoline with psychiatric oversight. In case of pregnancy, discontinue dopamine once pregnancy confirmed. Continue if macroadenoma or residual mass is present. Monitor visions. Now the hypoprolactinemia cause the pituitary dysfunction. For example, the Sheehan syndrome. Sheehan syndrome is a rare condition that is due to the severe blood loss during or after childbirth, leading to postpartum pituitary necrosis. Second is radiation and surgery. Hypophysitis, the autoimmune type, the excessive dopamine agonist or dopaminergic drugs, for example, levodopa. The clinical relevance, failure of lactation after delivery. This is the most specific sign. Amenorrhea or infertility due to associated pituitary hormone deficiencies. The hypoprolactinemia is often a part of panhypopituitarism. Other hormone losses usually more clinical significant than prolactin deficiency alone. Under treatment, there is no direct prolactin replacement therapy exist. The mainstay of treatment is to treat the underlying pituitary disorder and manage the associated deficiencies. For women who cannot lactate due to hypoprolactinemia, the supportive management include donor milk or formula milk. Now the prolactin and bone health. Chronic hyperprolactinemia, which cause the chronic estrogen and testosterone deficiencies. Because of estrogen and testosterone deficiency, there is increased bone resorption and may lead to osteopenia or osteoporosis. So evaluate bone mass density if prolactin elevated more than 6 months, especially in men and postmenopausal women. And treat with calcium, vitamin D, weight-bearing exercise, bisphosphonates if osteoporosis. Key clinical pearls or red flags. Mild elevation of prolactin, for example, 25 to 50 nanograms per milliliter, is often drug-induced. Major adenomas usually produce prolactin more than 200 nanograms per milliliter. If there is a stalk effect, which can give 30 to 200 nanograms per milliliter, always rule out pregnancy and hypothyroidism before imaging. Cabergoline is markedly superior to bromocriptine for tumor shrinkage and normalization. But cost and pregnancy favor bromocriptine. Vision loss or pituitary apoplexy is an endocrine emergency. Urgent imaging, glucocorticoids, and neurosurgical evaluation may be there. That's all for prolactin. Please give your valuable comments.